Hello, and thank you for joining the Donut of Destiny. This is a special industry-sponsored episode. References to a specific product, process, or service by speakers during this podcast do not constitute or imply an endorsement by the Society of Cardiovascular Computed Tomography. The views and opinions expressed do not necessarily reflect those of the Society of Cardiovascular Computed Tomography. Thank you for joining us.
This episode is sponsored by HeartFlow, the leader in AI technology for coronary artery disease. Imagine a world where CAD is no longer the leading cause of death, but a condition that can be proactively managed for life. That's the future HeartFlow is working to create. It all starts with a single CT scan. HeartFlow's AI-driven analysis then creates a personalized 3D model of the heart that helps you make the right clinical decisions with greater clarity and confidence. Discover the future of CAD management today at heartflow.com.
Hello, listeners, and welcome back to the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist from Dallas, Texas. We are recording this episode in early May 2025, which is shortly after the ASM for SCAI, that is the Society of Cardiovascular Intervention and Angiography. At this meeting, a novel inter-society multidisciplinary expert roundtable document was presented and had the following title: Coronary Computed Tomography Angiography to Guide Percutaneous Coronary Intervention. So this roundtable document is now in press, and we will make sure that the link is available in the show notes for the episode. The document is essentially a state-of-the-art review on the practical applications, the currently unmet needs, and the future directions of coronary CTA-guided PCI. And on today's podcast episode, I have the privilege of having the chair and co-chair of this roundtable joining me. That is Dr. Yadhir Sandoval and Dr. Jonathan Leipzig. Dr. Yadhir Sandoval is an interventional cardiologist with the Alina Health Minneapolis Heart Institute at Abbott Northwestern Hospital, and Dr. Jonathan Leipzig is a professor of radiology and cardiology at the University of British Columbia. Gentlemen, welcome onto the podcast.
Thank you.
Thank you for having us.
Fantastic. Thank you both. While I'm sure many of our listeners know y'all very well, I do want to get an idea as to, your background in interventional cardiology and cardiac CT and how it pertains to, the topic at hand, CCTA-guided PCI. Yadhir, why don't we start with you?
Sir, Praveen, thanks for having me again. So I'm an interventional cardiologist, really specialized in coronary interventions, coronary artery disease. Really the focus of my practice is in intravascular imaging, coronary physiology, coronary imaging. And while I had trained level 2 in CT, again, my practice had been really focused on the invasive applications until the past, a few years where we've started learning the opportunities to bring in CT from a diagnostic tool to now an application to guide PCI.
Awesome. Thank you, Yadhir. And Jonathan, how about yourself?
Yeah, it's so wonderful to be here with you, Praveen, and obviously with my friend Yadhir. I think we're on a very exciting new path. My course, as it relates to cardiac CT, really started, of course, with trying to understand coronary CT as it relates to diagnosis and prognosis, and of course, trying to understand the informing of medical management. But at the same time, I was trying to explore the utility of CT to plan structural heart disease interventions. And over the last decade, so many of us have put on a lot of effort to really get to the point where, of course, as you know, CT is fundamentally ingrained in the planning process for structural interventions. And I think it's now high time, particularly with the updated chest pain guidelines, where CT is a class 1 indication, where CT is being done so much more ubiquitously in the workup of patients with symptoms, that we really start to explore and continue on this journey to use CT to plan coronary intervention. And having met with people like Yadhir and obviously the leadership of Carlos Colette and others, I think that this is a really exciting time, a culmination of both the quality of CT that we've seen now and also the significant interest from our interventional colleagues, an opportunity for us to really make a difference for our shared patients.
Fantastic. Thanks, Jonathan. I think that leads nicely into my first question about really the background of this roundtable. Why is it that SCAI and SCCT felt that this document was needed at this time? I know, Jonathan, you were alluding to the current landscape of coronary CTA and the diagnosis of primarily stable chest pain, but this is something beyond that, planning PCI. Jadar, why don't you help set the stage for us as to what brought these two societies together to create this document?
Absolutely. So, as Jonathan alluded from his background, uniquely using CT to guide structural interventions, the fact of the matter is that, as he indicates, we have been using computed tomography to guide a number of interventions in interventional cardiology, whether that is TAVRs, tricuspid or mitral interventions, left atrial appendage occluders, vascular procedures, et cetera, et cetera. And I think the question has been more, why haven't we been using this for coronary artery disease and coronary interventions? And just a number of these elements came together at the right place, right time, from the right technology, the right software, the right data, that even at a societal level, it became clear that there was an opportunity to address what were the unmet needs and future directions. To me, something that was a particular motivation was that we just had a little bit more data. And there's an ongoing pivotal trial randomizing patients as we speak, CT guided versus IVUS, that has had a lot of traction and interest. But as we await that trial, there are already two trials on CT in patients with prior bypass, in patients that are referred to the cath lab. There's a randomized trials in patients with CT PCI, and there's even a recent pilot trial in patients with osteal intervention. So I think we can discuss all these elements that came together at the right time, but I think the data has been increasing to the point that we could just not shy away from the fact that this is something that we have to face and understand how to approach moving forward.
Excellent. So the culmination of data and interested parties seems to be the origin of this particular roundtable, which is manifest in this document. Jonathan, could you talk to us about who this roundtable is for? Is this for imagers? Is this for interventionists? All of the above? Anyone else?
Yeah, no, I think it's really for all of the above, but beyond that, as you point out. I think we really wanted to come together to really provide a roadmap to understand, where the state of the science is, where it's likely going, where the data gaps are, but also the needed tools, whether software, hardware, technologies needed to really support the integration of coronary CTA in PCI planning. So from an administrator perspective, or a health network, to really understand if you have a main site, let's say, which is doing the more complex PCI, to really make sure that the CT supporting that practice is not just 64 slice, as you know, but rather more modern, whether it's with broader Z-axis coverage or multiple sources and detectors to improve the temporal resolution, or ultimately a photon counting platform. Some higher level of technology and hardware support needed to really do more advanced CT PCI planning. And then also a call to action for the software vendors to develop purpose-built pathways and software tools that are really facilitating or aim to facilitate the workflow, very specific for people like Dr. Sandoval and his colleagues, not just for people like us who are reading it strictly from a diagnostic perspective, but really similar to what we've seen in the mitral space, tricuspid and aortic space, software workflows that are really facilitated for planning PCI. And then ultimately, I think what I got the most out of the discussion was really reflecting on the state of the science and what has been done, but also the unique opportunities and the thinking that is happening by our interventionalists as it relates to treatment planning. And I hope that with this document, we'll not only see ongoing investigation and penetration of CT in the cath lab, but also improved communication and dialogue between imagers and interventionalists alike, the way we do for structural disease. Because we learn so much when we come together and share cases and hear each other's perspectives. It was really an incredibly rewarding experience, and one that I'm really grateful for.
I love that, Jonathan. Great overview of the contents of the document, and especially intriguing, provocative almost calls to action. I do want to touch on some of those later in our conversation, but for the listeners, I'll briefly and roughly break down the sections of the document based on the way I read it. It begins with introduction and definitions, then moves to a description of the benefits of CCTA-guided PCI. There's a subsequent review of the current literature and ongoing studies. There's a really, really cool how-to guide with tons of images on how to use CCTA for specific lesions. And then it concludes with the current limitations to applications, but future directions on how to tackle those. So let's break each one of these sections down. I want to begin perhaps with a fun way of going about the benefits of CCTA-guided PCI. So Jader, I am a skeptical interventionist. Can you convince me to use CCTA PCI?
Absolutely. So I can tell you it is fair and to have some degree of skepticism because, again, this is a tool that has been around for quite a while. And why should we change how we've been using it? And the reason we did, and I was a proponent of this, was because once we start interacting with the data, which is something that I think Jonathan will really promote, that we shift from just looking at a report and looking at a PDF. This is what most interventional cardiologists do, right? We just go to the electronic health record, see that the report that you guys complete says there's some CAD and a cath is recommended. But if we go beyond that and look at the actual images, either together with you guys, because some of us may not be familiar with how to, address the buttonology and pull the images, or if we become familiar with how to interact with the data, if we look at the images, it totally changes the game. It changes the game. And yes, we're waiting for this pivotal data and what is going to be the impact on clinical outcomes and procedural success rates and research utilization. And yes, we want those trials. But I can tell you that myself and in our practice, we've been early adopters of this because it's just a great triage tool. There are healthcare systems out there, including ours, particularly in our healthcare system in the US, there's a lot of heterogeneity. There are some cath labs that have all the potential resources and tools and gadgets, but there are other labs that may not have surgical backup. There are other labs that are more office-based ambulatory surgical sites. But we all know coronary disease is quite diverse in its manifestations and complexity. So CT just becomes a great tool that I can take a look and say, look, this is a non-calcified focal lesion. This can be done at any available time, but by any available interventional cardiologist and at any location without any particular restriction. Whereas if we look at the CT, and now not from a diagnostic perspective, but from a therapeutic perspective, and we say, look, this is a heavily calcified lesion with diffuse disease, subtotal or total, and we understand that this is very complex. Now we can triage this in a totally different way. I can say, I want this case to be done early in the morning by one of our complex operators. We can anticipate the equipment that we may need. And importantly, we can even go ahead and participate in shared decision making with the patient, in which we tell the patient, hey, this is going to be a complex case, and we can have those discussions about the anticipated benefits and risks beforehand. So to me, this was just incredibly valuable information that we had not really interacted with and engaged with before from that particular angle. And I like to say that, to me, the number needed to be convinced that this is of value, it's low. And once you do a few cases, you understand that this is very valuable.
Jader, you're a very adept interventionist that uses CT for these complicated and even perhaps now routine PCI planning. But for sites that are intending to start this, say, from the ground up, or at least convince the stakeholders to commit some resources to utilizing coronary CTA to help guide PCI, I sense that they'll want what we'll describe as evidence supporting this beyond just our expert users. Jonathan, I want to bring you in here and help convince my skepticals, other stakeholders with the evidence available to tell them, is it really beneficial to use coronary CTA in planning PCI? How have the data demonstrated this?
I think it's an important question, but I think as Jodar, obviously a fundamentally important question, but as Jodar highlighted, I think we do need to frame, first of all, what we're talking about. We're not talking about ordering a CT when it wasn't otherwise ordered and the patient's already referred to see Dr. Sandoval, but rather we're talking about really imploring Dr. Sandoval with his imager in this case to really understand the richness of the data that is available to inform their procedure. So I would ask you, what is the barrier to entry is different than if we were supplanting another test or doing a test when it wasn't otherwise ordered. So as far as actually improving outcomes, I think one of the things that we've seen is that it has opportunity to drive operational efficiency. As was mentioned, whether it's the bypass CTA trial or other smaller randomized trials in the CTO space and beyond, it can help predict procedural success, reduce contrast load, and reduce fluoroscopic time at the time of the procedure. We have data that go back over 20 years that suggests that CT can provide you an understanding, of course, of fluoroscopic length and lesion length, vessel size, also fluoroscopic angles, as we've done in TAVR since 2009. We can provide fluoroscopic angles that help optimize coronary position and lesion discrimination. All of these things are soft measures, but can only help and facilitate improved workflow. When we think about it, Praveen, I would imagine at your institution at Baylor Scott and White, you don't hear of many vascular surgeons going to a procedure to do an endovascular aortic aneurysm repair without even knowing if the patient has an aneurysm. And yet for really decades, our poor interventionalists have been going blind to the cath lab. And I think what we're talking about now is really exploring these data to really empower them with the sort of richness that a vascular surgeon would go to the procedure room with, right? She knows the length of the aneurysm, the size of the aneurysm, the neck of the aneurysm. And obviously there's some modification of treatment decision-making at the time, same with TAVR, but there's at least that fundamental awareness. So I think the path forward is shown every week in our P4 conversations, led by Dr. Collette, and I know Dr. Sandoval's team is enrolling. It's really then going to the cath lab knowing that you're likely going to put in a stent of this length. The physiology from FFRCT, the phenotype of the pressure loss, whether or not you're likely to use lesion preparation. These sorts of things really just empower the proceduralist to really understand what she or he is going to uncover at the time of the procedure. Now, what evidence do we need to actually get funded to do these analyses and do additional work? I think that's where, we will need more evidence, right? And Dr. Sandoval and I have spoken about this, what sort of evidence I think we need to see, again, improved procedural efficiency, reduction in contrast and fluoroscopic time, and then ultimately, I think more complete revascularization as a routine would be a nice goal. I would share with you that has been shown by a number of the ischemia investigators, a lot of the work led by Greg Stone and others, that half of the patients in the ischemia trial were incompletely revascularized. And so, of course, some patients can't be completely revascularized. Obviously, Jodar can elucidate why, but there's no doubt that going to, in my opinion at least, that going to the procedure room with a plan can only reduce the likelihood of incomplete revascularization. I think we need to show that, but I'm fairly confident that data will over time.
Jonathan, as an imager, I spend a tremendous amount of my clinical time creating roadmaps for our vascular surgeons, for our structural interventionists to plan each of their procedures. And we then subsequently review the success of the roadmap that we created. So yeah, that resonates so much with utilizing the same paradigm of thinking in these other disciplines, but applied to percutaneous coronary intervention. With that in mind, actually, I do want to move to the so-called how-to guide that's provided in the document of how to utilize coronary CTA for specific lesion types. And rather than recapitulate all of the techniques that are described in the document, I'd like to ask both of y'all about two specific but commonly encountered lesions and how you approach them from the imager and from the interventionist perspective. These are heavily calcified lesions and bifurcation lesions. Jodar, could you help start us from the interventionist perspective as to how you use CT to plan PCI in these complicated cases?
Yeah, so the calcium one that you mentioned first, we can tackle that one to begin with. This is actually, I think, a fascinating story, right? Where all of us have been probably told not long ago, and many here listening, that we should be cautious about using CT in patients that have a very high calcium score or a high calcium burden, and that we cannot say much about from a diagnostic purpose what's happening because there's just a lot of calcium. As many of us have embarked on this journey now to UCT to guide PCI, we've learned that rather than a weakness of CT, seeing the presence or absence of calcium is actually a strength. Because right now, many of us would argue that do interventions that calcium may be the number one enemy of optimal stenting and unoptimal stent expansion. And this is for a number of reasons. But I mean, I'll elaborate on a couple of them that, again, sort of underscore why CT is incredibly valuable for case triage and allocation. But something that we forget, and I think it's an important message for the audience, is that in the US specifically, the average number of PCIs performed by interventionalists out there, it's around 50 per year per NCDI publications. And there's a couple of publications that have indicated this. And this is just for performing a PCI. Now think about the ability to tackle some of these more complex cases with complex techniques, whether that's rotational orbital atherectomy, intravascular lithotripsy, or the combination of all these techniques. These are complex procedures. So therefore, CT is just a great tool because if you know at the upfront that you have severe calcification, you can plan accordingly the case, as I mentioned before, where this should be done. You can have equipment that you may say, I would need a more supportive guide, a more supportive wire. You may even potentially anticipate the need for advanced calcium modification strategies. And again, so this is a very potent. There's a number of studies out there, just to elaborate just briefly and a little bit more on the calcium aspect, that have said, sure, there's a blooming artifact, and maybe Jonathan will speak to this on the second, but yes, there's a blooming artifact, and maybe some of the metrics like thickness of the calcium are limited. But the calcium morphology, the arc of the calcium, the length of the calcium, those are things that we're learning we can rely on from CT. Even as we've moved forward with this journey, we have learned that there are other metrics, and there's been some publications about this that are saying maybe there's even information out there that we can use that we were not previously looking at, like calcium density. So there's just a lot of information with CT with calcium, which I think it's worth maybe even just chatting a little bit before we jump into bifurcations.
Yeah, they're great points. Jonathan, would you like to flesh out some of the imaging-sided thoughts on those heavily calcified lesions?
Absolutely. I think this is one of the real opportunities when we come together as imagers and proceduralists. We bring a different lens to a problem or to a question, right? And it was very fascinating for me to see some of this work that's being done by Jodar and his colleagues, Dr. Collette's team and others, looking at this calcium distribution. And, when you and I look at it, we see it as a frustration, as an annoyance. I don't want to see this kind of calcium. And they look at it and see, oh, wow, I need to understand that because I'm going to be trying to treat this calcium as it relates to relieving the anatomical stenosis and optimizing stent expansion. And so the other example would be is, there's sometimes when we get weighed into understanding the limitations of CT, that is important for sure, whether it's the limitations of the spatial resolution or the partial volume averaging or the interplay between the blood pool and the calcium that can result in distortion of the actual amount of calcium. I think sometimes we get so caught up in that because that's our area of focus that we aren't willing to almost explore questions that need to be answered. And I think we'll continue to learn more as it relates to the calcium density and also the extent and being able to try to understand how these different imaging findings we may not have appreciated as being important as it relates to what we are doing, may be quite relevant as it relates to predicting stent expansion and wire bias and so on. And also as it relates to, the relationship between plaque morphology and the phenotype of physiology, there's a great deal of interest in that. Why is it that focal pressure loss is associated with more improved pressure recovery, but also more commonly associated with non-calcified plaque with very whereas very diffuse pressure loss is more commonly associated with diffusely calcified plaque. These are all questions that we're starting to be able to answer because we have more and more non-invasive tools that can afford us an understanding of atherosclerosis, but also physiology. But we also have the right eyes being set upon them, with that sort of question in mind and an understanding of what it is that the interventionalist is really trying to do with their procedure. So I think it's really fascinating to hear people come together with these different backgrounds and explore these questions.
Awesome. Super insightful points from you both about, unfortunately, maybe I should say now, fortunately, very common problem in CT that provides a lot of insight to our interventionists. Calcification, I've many times said, is the bane of many imagers' existence, but I perhaps should reframe my thinking on that, and that it can actually be very useful information when planning PCI in the future. I do want to touch a bit on bifurcation lesions because I personally, and I've heard from many of my colleagues, find it quite challenging to describe these lesions. And then beyond that, Jadar, I want to get your perspective on how you utilize the imaging data on bifurcation lesions to help plan these, from what I understand, quite technically complicated cases.
Yeah, so bifurcation PCI is very common. If I'm correct, I want to say that it's about 10 to 15% of all PCIs involve a bifurcation. And so it's a very common challenge out there for the interventionalists. Something that I think, at least in our journey, in my own experience, that really helped us further embrace the opportunities with CT and bifurcation, to be honest, was some of the FFRCT 3D models. Because yes, you can look at, you guys look at this all the time, in axial views and multiplanar reconstructions and try to, get this, reconstructions to really understand this. But this can be challenging for the untrained interventional cardiologists that may struggle to get some of these views. So we started using some of these 3D models to really understand, for example, optimal angulations, where are views and where we can reduce some vessel foreshortening. And again, another application that we thought about FFRCT as a traditional diagnostic tool, as a sort of like a diagnostic tool alone, is this functional significant or not? But now looking at it with the eyes and lens of how do we use this information now, let's say, to reform bifurcation PCI, and in which we said, well, can we better display the bifurcation? Look, this is a particular angle that we're learning from the 3D model that would be optimal for a projection. This will save us contrast. Look at these two side branches. We need two wires, and therefore we need a particular guide. And something that launched our experience into really jumping into CT-guided PCI, frankly, was that we had the fortune to be one of the early practice around the world in really using a virtual PCI, which allowed us to now say, all right, how about we play a stent provisional? What is this length of that stent provisional? And even simulate different stent planning techniques. And some of these issues are actually alluded to and illustrated in this SCAI-SCCT document as how you can even use some of these virtual PCI planning tools now to look at a number of techniques. You can say, here's a provisional approach. This is the length. How about if we jeopardize the branch? You have a backup plan that you were going to have one stent in the main branch, and there's going to be the length for the second stent in the side branch. Of what if that were the optimal approach from the beginning, a two-stent technique? So all of these things, as Jonathan mentioned, that are purpose built to help interventionalists have been really helpful for us to, and I would say bifurcation is a particular lesion subset where this is particularly helpful because it's a common problem, common dilemma, and it's one of those lesion subsets that it will be considered one of the complex lesion subsets for interventionalists.
Awesome, Jadar. That is so helpful from the non-interventionist imager side to hear that perspective. Super, super compelling. Jonathan, curious to know how your approach to describing bifurcation lesions has changed through this conversation or really previous conversations you've had with our interventional colleagues.
Well, I must say that a lot of the nuances around intervention, around bifurcating lesions, and I've been in this business, as you know, Praveen, a long time. I've read a lot of coronary CT angiograms post-fellowship, now 20 years. I don't even want to know how many I've read, and I certainly don't want to know how many I've read incorrectly. But, we all do the best we can, and we learn and we grow. But I really think these are complementary roles of the imager and the proceduralist, and that's why, we have our interventional fellows come and spend time with us in in the imaging lab. And originally we thought it was only to really learn structural imaging, but they really grab a hold of the CT data. And not only do they grab a hold of it as it relates to them learning how to interpret coronary CT, they teach us a tremendous amount about, their decision making and how they would proceed with a different type of procedure. And so I think that the bifurcating lesion is just but one example. I mean, another one, and I come back to it, is the pattern of pressure loss. This whole concept that, physiology is not a binary tool, but rather, it's a continuous variable, and the path to the abnormality is very important as it relates to predicting post-PCI physiology, also angina relief, and perhaps also in understanding the mechanism of spontaneous MI. So it's not that I don't try to grow and really learn more about management and interpreting bifurcating lesions, but I also am aware of my own limitations. And I think the best thing that I can do is really partner with my colleagues in sort of multidisciplinary rounds, introduce what I can share as it relates to the CT data, and then be quiet and learn, because there's just so many nuances to it that I learn so much from people like Jodder when he speaks on the topic.
Brilliant. I think that this is just a compelling case for the multidisciplinary approach to the use of this tool in many, honestly, if not all, PCI that we have CT available in already. I think this leads nicely into a discussion about the potential barriers to current application. There's a great figure in the document that illustrates a variety of different barriers and, importantly, potential future solutions to widespread adoption of this. Some of these barriers I found quite compelling, or really the solutions to these barriers were quite intriguing. Jonathan, you had mentioned a couple of them. No more 64 slice scanners. That was quite interesting. An increase in the number of software licenses at institutions, including specifically for our interventional colleagues. And finally, how to bridge coverage gaps. And wanted to get insight from both of y'all on the exposition of these and perhaps other barriers I didn't mention for our listeners, and perhaps how they can help contribute to overcoming some of these barriers. Jodder, why don't we start with you here?
Yeah, so this is actually of the many things. This is, I would say right now there's a number of trials, data, education to increase awareness about the opportunities. But inevitably, this is where the rubber hits the road, and people are like, "Well, this is great, Jolly, Jonathan. You guys told us about the opportunities, but now I'm facing these barriers." And this is where I'll speak about our experience at our site. The reason we have been able to really been early adopters of this in clinical practice, because again, just to emphasize this, for example, we are part of the P4 trial, and right now, have the fortune to be the highest enrolling site in the U.S. for this ongoing randomized trial. But we do CT-guided PCI routinely for patients in our in our day-to-day clinical practice. And the question is, why has that been? This comes back to it doesn't happen in a vacuum. This is a team approach, a true multidisciplinary partnership. At our site, I have the likes of colleagues like Dr. John Lesser, Cavalcante, Cheng, a number of colleagues that have really unique expertise in a number of these softwares out there and applications. In the context of their expertise, we were able to therefore implement a CT-guided PCI. So I'll just give you a couple of examples that are in the barriers. And when we talk to other colleagues, this is something that they encounter frequently. And then we learn, all right, that's an opportunity. I'll give you two. One is access to the software. So I have the ability to open up coronary CT interrogation software that we use in our clinical practice anywhere. I can open it in my office, in the clinic, in every cath lab room, and therefore I have really no excuse to not interact with the data because the software has been made available to me and my colleagues. This is something that it's not the case for many interventionalists out there. And again, for the audience of this podcast, that it's maybe imagers, I would invite that as we try to embrace these opportunities. Therefore, we have to make these tools accessible to our interventional colleagues for them to learn about this and then work together, right? The other one is but not only the access to the software, but it's this partnership. So I can tell you, as I mentioned earlier in the podcast, I had training level to CT, but I had to rethink how I wanted to approach this now for CT-guided PCI. And my imaging colleagues were able to lend a hand, right, and say, well, this is this particular tool that you can use for this, for that. This is this particular other one that let me show you this tip and trick. And they initially were holding my hand for a number of these applications, and eventually you just walk, and for the most part can walk independently, and every now and then can always pick up the phone or go downstairs where they are and go over some particular case that you might need some help. One thing that I can think of, once they understand that you understand the applications, the pros, the cons, other opportunities that you may have not envisioned pop up, right? One is, for example, we started doing a lot of this, virtual PCI guidance. And inevitably, we were doing enough number of virtual PCI guidance that I said, like, hey guys, I need to have the ability to perform FFRCT to do these cases on an ad hoc basis. And the imagers, traditionally will say, FFRCT, it's an application just by the imagers, but by this relationship and this multidisciplinary collaboration and learning from each other, they're like, oh yeah, our interventionalist Jolly is using this now for virtual PCI guidance. We're going to provide him with access to this tool, and therefore we've been able to really champion this effort. So, but to me, I just want to underscore that it doesn't happen in a vacuum. It's a partnership, and from an interventional perspective, the number one variant that interventionalists have that I hear again and again is that they don't have access to the software because of this issue of licenses. And this is where the field, and this is where it's great to have our society backing in SCAI and SCCT. We need to rethink how do we make these tools available to the users.
Jother, these insights are invaluable, especially the specific examples you've given as to how to empower all of our colleagues, specifically our interventional colleagues, to utilize the richness of the CT data to help treat our patients. Those concepts of, quote, how you do it at an expert site are so helpful for sites that are starting these budding programs in which these relationships are just nascent and we want them to be fostered, to flourish. Jonathan, from the imager side, can you speak to how either you or of colleagues overcoming some of these barriers to increasing the application and widespread use of this tool for our interventional population?
I think the big thing is, and what I saw also in the structural heart disease space is, I think we've highlighted the need for access to imaging software and also improved communication. But I do think workflows that really make sense to the interventionalists are really important. When I joined for those same calls around the P4 trial, the elegant image presentations that are brought together by the amazing team at OLV, it's really a thing of beauty. But the reality is most of us, of course, don't have such a team to put these images together in preparation for each individual case. Of course, this is what we're seeing at MHI now, the real-world applications of CT-Plan PCI and other centers across America and the world. But I think it'll become more routine as more and more interventionalists train in the space and really grab a hold of these data. I think as the fellows really embark on this and see this as an opportunity for them to bring to different sites their knowledge to really enrich it as they look for jobs out there, but also when there's workflows. And we saw this in the early days of TAVR when CT workstation tools were developed or specific softwares were developed that I originally saw that I thought to myself, well, this doesn't offer me this or doesn't offer me that. But the reality was it was purpose-built to offer the procedures exactly that which they needed to plan their procedure and nothing more, in a fashion that they felt comfortable. And I think that's where it will be incredibly important to do. I mean, I'm already aware of some softwares being developed integrating, physiology and post-PCI physiology and all of this in a sort of a streamlined way. And I think this will be very important because it will sort of democratize the technology, make it easier for interventionalists to feel comfortable with it and really use it in their practices.
Excellent. Even the microcosm of this conversation as a collaboration between imagers and interventionists is seemingly key for allowing our patients to gain access to this honestly invaluable tool in planning percutaneous coronary intervention. I do want to start bringing our conversation to a close and ask you both, Jother and Jonathan, what your final thoughts are, not only for this document, but for the direction of this field in the future. Jother?
Yeah, I think it's been a great conversation, and we've touched on many of the key aspects. To me, one particular issue would be education. We are, I would say, at this particular point, to some degree, in interventional cardiology, I think we've seen, as Jonathan was saying, we've seen some of these pretty images that are very impactful and well put together. We are aware of some of the ongoing data, but now we need to understand how to perform these assessments. And that is where these purpose-built tools need to, hopefully there will be ongoing iterations to enable their use. But then interventionalist cardiologists need to be educated about how to use them, because again, I really like this phrase that Jonathan really hammers when we talk. Is this issue? We interventional cardiologists, we need to interact with the data, and for that, there needs to be education to really hammer on what the opportunities and strengths of this are, and why this is value for clinical practice and our patients. Our goal is to improve patient care, to improve workflow in the cath lab, to improve research utilization. But again, to just do better for our patients, and we can only do that by now learning people how to drive the boat.
Awesome. Thanks, Jather. Jonathan, any final thoughts before we close?
Yeah, I don't have much to add to that. I really want to thank you for the opportunity, and I'd love to come together in another year and see where we're at as a field. I think this is, again, it's hard to predict the future, but the path has been mapped out for every other procedure, as we talked about, right? Whether it's coiling an intracranial aneurysm or treating an abdominal aortic aneurysm, we know that imaging with anatomy, function, in this case physiology, plaque morphology, these things are so obviously important to procedural planning that I think if we gathered in a year, we'll see that this is much more commonplace, and I look forward to seeing the data and the experience evolve over time.
Excellent. Jather, Jonathan, thank you both again for coming onto the podcast. Super appreciate the time that you've dedicated just here, but also the expert contributions to this roundtable and to all of the science that has contributed to the roundtable. So super thanks and kudos.
Thank you for having us, Praveen.
Thank you so much, Praveen.
Of course, thanks again, y'all. And for our listeners out there, thank you very much for tuning in. I will link to this document in the show notes of the podcast. Be sure to check it out. It is absolutely awesome. Thank you, as always, for tuning in. We really, really appreciate it. And it would be great if you all could rate, review, and subscribe to the podcast. That helps others out there from the entire cardiovascular imaging and medicine community find content like this. Once again, this is the Donut of Destiny. Cheers.